Good morning, everyone, and a warm welcome to the third day of the 5 Days in May BC Health Research Showcase. This session will be focusing on seniors' health at Fraser Health. My name is Magdalena Newman. I'm a manager for research and engagement at the Fraser Health Authority and a lead for the Fraser Regional Center of the Provincial Support Unit for Patient-Oriented Research. It's my pleasure to facilitate this morning's session. And with respect and gratitude for the lands from which I'm joining today, as well as for the people who have been shepherds of this land for millennia, I'd like to acknowledge that I am on the unceded and traditional land of the Tsleil-Waututh, Musqueam, and Squamish nations. My workplace, Fraser Health, is located in the unceded and traditional homelands of the Coast Salish and Etna-Kapama nations. In recognition that many of us here today are joining from places across BC, I invite you to post in the chat which traditional lands you're joining us from today. And now it's my pleasure to hand the mic over to Suzanne Fox, Executive Director for Fraser Health Integrated Long-Term Care and Assistive Living, to introduce this morning's session.
Thanks so much, Magda. So happy to be here with you all this morning. And as introduced, I'm the Executive Director for Long-Term Care and Assisted Living at Fraser Health Authority. Super excited that you get to hear about the work we are doing in our health authority around seniors. Also want to welcome you today to the third day of the 5 days in May. And also want to acknowledge where I'm working from today, and that's on the traditional territory, the Sineemu people. So I'm grateful to be here today and to be able to work and play on this land. Many of you may know Fraser Health is a very large region, and we cover Boundary Bay to Boston Bar, or sorry, Burnaby to Boston Bar. And we have a large population. About 20% of our Fraser Health population is over 65. From a seniors facility perspective, we have 93 sites that are long-term care and 58 that are assisted living. So who we are responsible and somewhat accountable for ensuring we're caring for. I may be a little bit biased, but the long-term care and assisted living program over the last year in Fraser Health has embarked on a 5-year strategy. And in and amongst that strategy, we've had the expansion of our research efforts within long-term care and assisted living, and the establishment of a research unit, which is doing extremely important work and having much success. And you're going to hear from some of them today. So today's sessions are highlighting several projects underway. Areas are focused on frailty in LTC and fracture management, and then a little bit about how that research unit was stood up. And with that, I want to wish you nothing but success in your sessions today. And I know there's time crunch, so I will stop there and thank you very much. And ask all of you to hold our seniors in your hearts today as you learn and what we can do to improve the service we provide for them.
Thanks so much, Suzanne. Just a few housekeeping notes before I introduce the first speakers. We have 3 wonderful presentations for you this morning. There will be a 5-minute question and answer session after each presentation. And I'll be keeping an eye on the clock as a facilitator for today. And I may interrupt if the presentation looks in danger of running long to ensure that all presenters get a chance to speak. I ask that we keep to 1 question per person during a question and answer session. If there are questions from the audience beyond the 5 minutes, I invite you to please post your questions in the chat, and for the presenters to respond in the chat as well, following the 5-minute question and answer. And it's now my pleasure to introduce the first talk for today, Partnering for Change in Fracture Management. And our speakers are Dr. Sonia Singh, Stephen Smith, Larry Fennell, and Dr. Tanya Bubala. Thank you.
Great. Thanks so much, Magdalena and Susanna, for starting us off. And I'm just going to share my screen so that we can get started with our team's presentation. Good morning, everybody. It's nice to see so many people on the line. And I'm really excited today to be able to join some of my team members to take you on our journey partnering for change in fracture management. And I wanted to acknowledge our financial sponsor, which is Michael Smith Health Research BC. So during this presentation, we're going to take you on that journey that we went on to look at first, why change is needed, what is the gap in care, and how we discovered Fracture Liaison Services, or FLS, which is a model that really does close this gap in care. We're going to briefly touch on FLS evidence globally and locally, and then move on to our research, what we hope to achieve over the next few years, and then end up with a little panel discussion with all of our team members on the Zoom today around why partnerships were so important in this project. Now, to start us off, we really do need to understand why change is needed. And I'm going to pass over to my project co-lead, Larry Fennell, because he's the best person to show us why change is needed.
Thank you, Sonia, and good morning to all. I'm pleased to be here today to share my perspective on a research project that exemplifies the value of effective partnerships. I didn't hesitate when I first learned of the opportunity to join Sonia's team in applying for funding from the Michael Smith Foundation. It was a natural and exciting extension to the collaboration that brought the first fracture liaison service to British Columbia. My desire to participate was also deeply personal, so let me explain. By the time I was diagnosed with osteoporosis in 1998, I had already suffered 8 fractures. Like those around me, I thought it was accident prone and more than a bit unlucky. For me, a slip on wet grass or tumbled into some empty cardboard boxes meant a broken bone, yet another trip to emergency, perhaps another cast, and months of physiotherapy. I suffered blinding pain. I watched helpless as others performed even the simplest of tasks for me, and I endured lengthy periods of convalescence, unable to work and reluctant to socialize. I broke bones on 2 different continents in 3 different provinces and was treated for the fractures in 7 different hospitals. In spite of all the obvious hints, it never occurred to me, nor did it occur to the many healthcare professionals who treated me, that the fractures were somehow connected to my bone health. The fractures received excellent treatment. The underlying cause of the broken bones went unnoticed and untreated again and again until my wife's doctor, upon hearing the story of my repeated fractures, ordered me to get my bones checked. The diagnosis that followed set me off on a long journey to answer 2 questions. Why wasn't my osteoporosis diagnosed much sooner? And how could I end the cycle of recurrent fractures? With help from the experts at an osteoporosis clinic, I began a regimen of treatments that included a progression of medications and lifestyle changes. And I finally stopped breaking bones. My spirits lifted, my confidence grew, and I regained a quality of life I had not thought possible. I gradually came to realize that the question was, why us, and not just why me? I wasn't the only one trying to understand how so many people could fracture over and over again when proven treatment was so readily available. And I was shocked to learn that the gap between the science and the practice of osteoporosis management had for decades resisted all attempts to close it. My desire to learn more about the mismanagement of the disease prompted me to become engaged in the research to find out how to close the gap. That led me to connect with Dr. Singh more than a decade ago. I understand that my lived experience could be an important contribution to research. I also learned that I had more to contribute than my patient experience. For example, my career as a public servant taught me the importance of building diverse teams, how to deal with disappointment, the need to be adaptable and persistent to transform science into practice. So although my osteoporosis is a part of who I am, it does not define me, nor does it encompass all the knowledge, skills, and experience I can bring to the table as a research partner. The significant strength of our team is the mutual acknowledgement and embracing of the many talents hidden behind the labels for each of the team members. I'm proud of the fact that Whether through design or good fortune, I've been fracture-free for 22 years. That being said, my osteoporosis is a constant nagging companion, reminding me of the things I should not do or the foods I should not eat. That nag also motivates me to continue looking for answers. And with that, I'll turn it back to you, Sonia.
Thanks so much, Larry. I mean, when I first heard Larry's story, I was shocked. And I'm sure that you may be shocked when you hear his story. But unfortunately, his story isn't unique. And in my 25 years as an emergency physician, I saw lots of patients just like Larry. And it was those stories that really inspired me to try to do whatever I could to close the care gap. So what is the situation around osteoporosis in Canada? Well, the evidence shows that 1 in 3 women and 1 in 5 men are going to suffer a fragility fracture or a low trauma fracture due to osteoporosis over their lifetime. And there are effective treatments, as Larry's mentioned, to prevent another fracture. They're widely available, yet 80% of patients are not treated to prevent another fracture from happening. And they continue to break bone after bone without being treated. And this leads to what Larry mentioned, a cycle of recurring fractures. And our team was determined to do something to break that cycle. And so we discovered, as we were looking through different models of care, the Fracture Liaison Service, or FLS model. And the core of FLS is having a dedicated coordinator that works alongside the orthopedic staff. So while the orthopedic staff is dealing with the immediate fracture, the healing, the rehabilitation, the FLS coordinator is looking at identifying those patients who may have an osteoporosis-related fracture, making sure that they have the appropriate investigations to assess their risk of repeat fractures and falls, and then initiating the appropriate treatments that are specific for that patient. This would include education, lifestyle changes, perhaps osteoporosis medications, and the referrals that are right for them. So sometimes to an osteoporosis specialist or to a fall prevention clinic. And throughout that process, having communication with the primary care providers in the community. We have global evidence now that this type of FLS actually works. And over the last decade, we've shown that FLS increases treatment initiation, treatment adherence, but most importantly, it decreases refracture rates and even decreases mortality rates. When we first started our work in 2013, there were no FLS programs in British Columbia. And so our team started the first FLS at Peace Arch Hospital in 2015. And we had the support of the Canadian Institute of Health Research and some funding also from the Peace Arch Hospital Foundation. And we did a before and after study to look at how well this FLS was actually working. And not surprisingly, we showed excellent results, similar to what had been seen internationally, with over a 3-fold increase in appropriate care in high-risk patients. So we know that FLS works. It works internationally, it works nationally, and we now had local evidence to show that a Made in BC model works too. We also have been seeing increasing numbers of cost effectiveness studies to show that FLS not only is cost effective, but actually saves money once it's been operating for several years. So our next step was, how do we spread this FLS model across BC so all fracture patients can benefit from this fantastic program? And it just so happened that in 2018, the Michael Smith Foundation announced their first implementation science competition. Now you might ask, what is implementation science? Well, it studies how research evidence can successfully be taken up into the healthcare system to benefit patients. We know that it's not enough just to prove that an intervention works. We need to make sure that it actually gets taken up into the healthcare system And this process can often take years. There's really a big gap between what we know works and the decision to make it part of the system. And I think this has become even more of an imperative during the COVID pandemic. So some of the questions that are asked in an implementation science project are, how do new treatments or programs get put into practice? What strategies are used, and do they work, and why? And if they didn't work, how can things be done better next time? So with this new project, we had to really expand our partnership within the healthcare system, within the academic community, within policy, within patients. We brought more patients to our team. And finally, we had to have funding to do this work. And we were very fortunate to be one of the 5 implementation science teams that was funded by Michael Smith for a 3-year term. Our new research question was, how could the FLS model that was implemented at one hospital site in BC be successfully scaled up to other sites within Fraser Health to ultimately inform spread across the province? Now, to help us with this project, we used 2 implementation frameworks. One's called the Consolidated Framework for Implementation Science, and it helped us look at what factors influence how well a new intervention will be taken up at a new hospital site. What kind of barriers and facilitators do we need to be aware of? How to identify how best to engage all of the multiple stakeholders that we needed? And finally, to really help us plan our strategies for successful FLS implementation. So this was the framework that we used before putting an FLS into place at a new site. Now, of course, once we had an FLS up and running, we wanted to evaluate how well it worked. And so we used the Re-AIM framework that had 5 dimensions to it. First of all, how well were we reaching our target population of patients? How effective was our FLS in terms of patient processes and outcomes expected? How well was the program adopted by the staff at the new sites? And how well was it implemented based on predetermined quality indicators? And finally, how were all of these 4 aspects of FLS being maintained over time? We used a multiple case study design, and what that is looking at each hospital as a separate case and taking a deep dive into what was happening at this hospital as we started to move forward with FLS implementation, while we're doing implementation, and after. We're going to be collecting many different sources of data, including interviews, administrative data, and surveys, and then incorporating all the data together to better understand what processes, tools, and models were most effective. And because we're doing this work at different hospital sites, we're going to be able to do some cross-case comparisons. So this diagram gives you a bit of an overview of what we've been doing over the last 3 years since our grant was awarded in June of 2019. We've started working with the Royal Columbian Hospital starting in January of 2020. We then moved on to Chilliwack Hospital last year. And then a surprise happened. Kelowna in Interior Health and Richmond Hospital in Vancouver Coastal also started moving ahead with their own FLS implementations. And we've started collaborating and partnering with them as well. And so there's really been a huge collaboration, a huge swell of interest in FLS across the province. And so we decided that this was a really good time to host a BC FLS forum that's going to take place in October of 2022, where we're hoping to start planning a more provincial FLS spread. Now, throughout the project, we've also been doing our evaluation using the Re-AIM that I described earlier. And from the very beginning of the project, we're also doing a longitudinal study recruitment, which is going on at the established Peace Arch Hospital FLS. And that's to look at that maintenance component I was talking about, following patients over long periods of time to see if treatment recommendations are being maintained. And we're hoping to be able to finish this project in 2024. Now, it's a big project. It's very messy with lots of moving parts. And one thing that I've learned throughout this project is how the research team itself can be a very powerful tool for making change in the healthcare system. And in a few minutes, you're going to hear from my co-leads, Tanya and Larry. But I also wanted to highlight our executive sponsor, Linda Dempster, who's one of our VPs in Fraser Health. And it's so important to have somebody at that high executive level to support a big project like this. We also had a very rich and depth in our research team with knowledge, expertise, and experience that has been so invaluable for us. We have a number of researchers from UBC, from SFU, and within Fraser Health. We have an additional patient partner and several decision makers, one of which is Stephen Smith from the Ministry of Health, and you're going to hear from him shortly. And tying us all together and keeping us on track are our two excellent research coordinators, Evan Sidhu and Monica Lee. So I'm going to stop here, and I'm going to invite my other team members to join the discussion. And I have some specific questions for them. We're going to start with Tanya Bupala, the Dean of Health Sciences at SFU and one of my co-leads. And Tanya, I just wanted to ask you, why are partnerships with academic researchers so important and have been so important in this project?
Yeah, thank you so much, Sonia. So first of all, thank you for the invitation to be here, and it's lovely to see you all this morning. I'm also on the traditional territories of the Squamish, the Tsleil-Waututh, and the Musqueam here on Burnaby Mountain. So I think academic partnerships are so important because we bring that academic or theoretical lens and some of the methodological frameworks to bear on the project. And we also have access to some of the workforce in the form of students, graduate students, and research assistants. And so given the lack of time for many clinicians to undertake research unless they have a dedicated research time within their clinical appointments, it is of benefit to partner with the academic sector to bring in that academic lens and access to those students. But also from our perspective, it's absolutely critical and essential for the quality and of the work and the potential for it to have impact is to partner with the knowledge of the clinicians. Now, Sonia doesn't really need academic partners because she is an extremely well-trained researcher. And what I have learned throughout this project is the absolute essential piece of the implementation puzzle, which is a very, very strong champion and a force of nature driving forward the momentum for change. And all of the academic research in the world is not going to create that force for impact and force for change. And so it's been my privilege to work with Sonia on this project. I'll leave it there.
Thanks so much, Tanya. I just wanted to say that that partnership that Tanya brings, as well as the other academic partners, has been so huge to guide us in our project, because implementation science is really a new area of research and none of us are experts. I'm going to now move on to Stephen Smith from the Ministry of Health. And Stephen, I wanted to ask you, what do policymakers need to support change in the system?
Thanks for the question, Sonia. It's a good one, and I'm sure many of the folks on the line would be quite interested in knowing what that requirement is or what those requirements are. I would say, you know, one of the one of the aspects of policy work that is front and center for us is how do we make some headway with some of those wicked problems that we collectively grapple with in Western society. So those really large scale problems that have plagued us for years, if not decades, and have really defied easy answers with respect to policy change or programmatic implementation. And I think one of the ones that really, I think, continues to plague us and continues to be a challenge over time is the needs of our aging population, and how some of the challenges that are experienced by older adults translate into limitations for them and needs that really draw on some of the healthcare resources and the social support resources that can be quite limited and expensive to provide within our societies in the Western Hemisphere. So I think that, you know, in the context of the FLS, as an example, we can see that the work is linked to that government priority, which is really grappling with that wicked problem of, you know, enhancing the health and well-being of older adults, while at the same time promoting that independence and mobility, which is important on an individual level in terms of maintaining health, but is also contributing to some efforts to offset the challenges and the dimensions of that wicked problem overall. So, you know, to dig a little deeper into the FLS example, I think that at provincial scale, this program could accomplish three things. It could support the short-term health of patients by preventing additional fractures. And Larry's story is a really good example of the kind of impact the program could have to individual patients. I think also, you know, Larry was able to demonstrate through his story, and Sonia's pointed to this in terms of her presentation, it supports the health over the longer term for the patient. So that reduction of recurrent fractures sustains mobility and promotes independent living. And that in turn offsets the risk of some of the challenges that we face in terms of very complex health problems like mental health problems and other chronic health conditions. And then finally, it can also at a population level reduce the need for extra utilization of intensive and expensive healthcare resources, which are limited in our system, and we know are sometimes challenging to provide at the scale that the demand suggests they should be. So by addressing those three things, what we're doing is we're actually looking at it, if I can borrow a term from Scrabble, a triple word score for policymakers. It's kind of checking three boxes at the same time: short-term individual patient outcomes, a longer-term benefit to patients, and at a population level, some significant changes that are going to offset health burden and demand for services over the long term. So I think that really illustrates, you know, a win at a policy level, and what we're really looking for in the context of some of the kinds of interesting results that will come out of research.
Great, thank you so much, Stephen. And it's just been wonderful to have Stephen be a full member of our team. And he's been so involved in our project and helping us network and collaborate with people at the ministry. I think we have 2 minutes left in our presentation, and I'd like to leave the last words to Larry. It can be challenging to find patients who are willing to engage in a research partnership. And I think our research partnership over the last 10 years is probably fairly unique, but what are your thoughts around that?
Well, it certainly can be difficult, and although there are a number of places and organizations to go to here provincially and even nationally. For instance, the Canadian Osteoporosis Patient Network is a good place to start if you're looking for research partners in osteoporosis. But maybe acknowledging who it is you're looking to recruit. So like me, many might not be interested in participating in research because were embarrassed, as in my case. I never spoke for 8 years publicly about my osteoporosis. I hid it from everyone but my family and my closest friends. Others are maybe too shy, or perhaps they lack confidence and they may not recognize their own hidden talents. And many might also feel intimidated about participating in research. So I guess what I'm trying to say is acknowledging and trying to make sure that individuals you're recruiting are going to feel welcomed and valued in your research project.
Great. Thank you
I think
so
my
much,
time is-
Larry. And I know that we're at the end of our time, so we're going to close and just thank you for listening so attentively to us.
And I'd like to thank everyone, Sonia and Tanya and Larry and Stephen, for taking us through what it takes to do a project like this and all the different partnerships that are needed, and describing to us what sounds like a really impressive and valuable service for the public. So thank you for your work. I'd like to now open up the floor for the question and answer period. We've got another 4 minutes. I ask that people please keep to one question at a time, unless we have time left over, and we can circle back if you have more questions. Okay, I've got one question in the chat. How does your team identify or screen patients at a specific hospital who might benefit from the FLS program?
That's a great question. Basically, the coordinator does the screening at the same time and with the same patient lists that the hospital does. So in the outpatient clinic, patients coming back to see the orthopedic surgeon after they've initially been to the emergency department for a fracture, the orthopedic surgeons have a list, and the coordinator screens the list, looks through the medical chart, may even meet up with the patients, and he or she does that at the same time that the orthopedic surgeons are taking care of the immediate fracture. On the ward, it's done through admission lists. So the coordinator screens the admission list from the emergency department and looks for patients that have fractures, and then goes into a bit more detail in their chart to see if they're the right kind of patients that we're looking for. I hope that answers your question.
Deveshi says thank you.
Great. Just to make sure that you understand that this is at the point of care. So it's not a referral clinic. It's sort of integrating that extra person right into the orthopedic team to make sure that it's all a smooth process. And most of the patients don't even know that there's a separate program going on called FLS. They just think this is all part of their fracture care. And that's exactly what we're hoping to achieve.
Any other questions for the team? Mike, you've got your hand raised. Please go ahead. We cannot hear you at present if you're speaking. We still can't hear you, Mike. Would you like to maybe type your question in the chat, and we'll move on to the next person until you've had a chance to type it in. Bernie, would you like to go ahead?
Yes, I'm a patient partner, and I've been doing this for about 10 years now. And I wonder how you ended up with the patient partner you did, or has partners interested in that work? It's a very interesting part of life, I can tell you. But if maybe we could identify that, maybe some of the places would like to involve more patient partners in that area?
Larry, do you want to answer that one?
Yeah, my interest started, I guess, when I attended the first public forum. And it was a public forum held by Sonia, coincidentally. And I was able to share my story with an audience of more than 100 people. And that was kind of the tip of the iceberg. It showed me that others were interested in what I had to say and made me realize that maybe there was an opportunity for me to do more. So from that point on, and with Sonia kind of leading the way, I got gradually more and more involved in volunteering and in participating in research projects, not just here in BC, but across the country.
Thank you.
Thanks,
for your
Bernie.
information.
So that's our time for the question and answer for their first talk. Again, I want to thank all the speakers. If you have any further questions for this team, please use the chat and hopefully someone from the team can hang out for a few more minutes to get to your questions. And now I'd like to introduce our next speaker for today, Dr. Xiaowei Song. She's a research scientist with Fraser Health Authority, the first one we've ever had in Fraser Health. And she's going to be speaking to us about towards early detection and management of frailty in community dwelling older adults, preliminary findings of the CIHR EFI-CGA research. And I'm sure she'll tell us what all those acronyms mean. Over to you, Xiaowei.
Okay, thank you very much, Meg, for the introduction. And thank you very much, Camille, for helping me sharing my slides. And good morning, everybody. I appreciate this great opportunity to talk about our research in promoting early detection and early management of frailty in older adults. I shall first spell out the term EFI-CGA that will appear in this talk many times. EFI-CGA is short for Electronic Frailty Index based on Electronic Comprehensive Geriatric Assessment. We receive a major CIHR operating grant to conduct this EFI-CGA research at Fraser Health. Over $1.4 million research funding, counting a small pandemic supplement. Next slide, please. In the original grant application that we put together with the great help of Dr. Kate Keach and several other DIRS people, the dynamic research team included many experts in the field of Fraser Health and of Nova Scotia Health, as listed in this CIHR funding decision letter. The team also has strong knowledge user collaborations and supports across Fraser Health and the province of British Columbia. And the project has involved the patient partners right from the planning phase. Over the years of project development, our research team has evolved and strengthened with many additions to effectively move forward day-by-day tasks. These people are listed in this box. The grant has helped support new research personnel, including research nurses. The team has also been enriched with more physician and the clinical program leader participants and 2 more patient partners or patient advisors. Next slide, please. The fundamental goal of the research is an improved system for integrated care of older adults. Specifically, we want to make the detection and management of frailty earlier. As we know, frailty is an age-related, multiply determined state of diminished physiological reserve that impedes resistance to recovery from stretches. Frailty is common in older adults and associated with many adverse outcomes, including cardiovascular events, falls, dementia, and this leading to hospitalization and even death. Back to a decade ago, we published this work with Dr. Ken Rockwood and Dr. Arnold Minisky, my then postdoc supervisors in geriatric medicine research. We analyzed large longitudinal Canadian national population health survey data of people aged 65 years and over. Our study estimated that by age 65 years and over, nearly 23% of people in the Canadian population were frail, more common in women than in men. The prevalence of frailty increased closely with age. For those people aged 85 years and over, 39% of men and 45% of women were frail. The data also showed frailty significantly increased the risk of death even when age and sex, gender were adjusted. The work turned out to be quite impactful with a large number of citations by other research publications. Here, frailty was measured by the Frailty Index, a widely used approach to quantify frailty with use of multiple health deficits in multidimensional domains. Next slide, please. The graphs show examples of deficit accumulation with age. Each subplot here shows an example deficit. X-axis represents age in years. Y-axis represents the proportion of people with the deficit in the population. Blue symbols and lines represent women data, and green symbols and lines represent men's data. As we can see, on average, the older people get, the more likely they are to accumulate multiple health problems and have worse health. Next slide, please. The formula. Constructing the Frailty Index is pretty straightforward. It is just by counting and summing up the number of deficits that an individual has, and then divide this number by the total number of deficits under consideration. Everyone may have a Frailty Index score. Lower score means healthier. Theoretically, the maximum Frailty Index score could be 1.0, meaning having 100% deficits accumulated. However, in reality, deficits accumulation has a limit of around 0.70% of deficit accumulation, beyond which immediate death or institutionalization is unavoidable. Here's another key point to note about Frailty Index, which is that deficits that make up the Frailty Index can be non-specific, as long as the number of deficits under consideration is sufficiently large, for example, no less than 30. These deficits should cover different physiological systems, and each deficit variable should meet the criteria that is biologically meaningful, prevalence increase with age in general, but not situated too early in adulthood. Here I list some reference papers for anyone who wants to know more about the background of the Frailty Index. Next slide, please. Thank you. The Frailty Index captures the fact of deficit accumulation with age and the social outcomes. Now let's take a look at this slide, demonstrating an excellent study done by a group of UK researchers using health record data of over 1 million older adults. Here, x-axis shows age in year. Y-axis shows the estimated mean number of survival in days. Firstly, we can see that on average, older people survived shorter than those who were younger. Meanwhile, at any given age, survival time varied drastically. And the older the people get, the bigger such a variation in survival until about age 90 years. What determined the survival advantages in some people than the other? It is the level of frailty. The color scheme here indicates, on the right side, indicates frailty index levels. So now when we scrutinize the 90-year-old people's data, we can see that even at age 90 years, people can gain up to 3 years of a survival if they were less frail with life deficits accumulated. Early detection and management of frailty is key for reducing the risk of deficits accumulation and to prevent health worsening. Next slide, please. We may now ask whether frailty index assessment can be done regularly at clinics. The answer is positive, yes. The standard comprehensive geriatric assessment evaluates multiple deficits and allows the development of individualized care plans for older adults. CGA is a common practice in standard geriatric care, typically use a paper form. The items assessed in CGA have been used to derive a frailty index. It is called a frailty index based on comprehensive geriatric assessment. We have reported how to construct such FICGA for example, in these papers. If the comprehensive geriatric assessment can be performed by family physicians in primary care, then older adults may not have to wait for geriatric services to have their frailty index, frailty levels assessed and the frailty managed. Next slide, please. To promote early assessment and manage frailty outside the specialized geriatric services, we developed an electronic CGA with an automated electronic frailty index. That is the EFI CGA. The CHR research project has allowed us to test the reliability and the criterion related to construct validity of the electronic of this EFI CGA in primary care, as well as the electronic CGA in primary care, as well as the electronic frailty index based on the calculation. Next slide, please. The project has 2 arms with a large number of planned tests. Briefly, the retrospective research arm involves the Fraser Health intra-eye data analysis on the EFCGA. The prospective research arm involves clinical EFCGA assessment in primary care compared with that in geriatric care. Today, I will talk more about the last part, the prospective arm. Next slide, please. Here I listed some key project components to develop the prospective arm of the study. The education, engagement, consent, and enrollment are multi-leveled, from primary care clinics to family physicians to the patients of the family physicians. At Fraser Health, we collaborated with the CARES initiative. At the Nova Scotia Health, we collaborated with the BRICS BREAK initiative, both a clinical initiative program. Each of these programs administrates care planning and clinical interventions, such as community coaching and social prescribing. Our research project provides the financial support to patients and physician research participants. The research team looks after the assessment scheduling. The research team also assists the assessment sessions themselves. The research team conducts data entry, data standardization, data management, and the quality control. Next slide, please. The research team also insisted the implementation, testing, and debugging of the EFCGA software on the EMR system, the electronic medical record system. To now, the EFCGA has become accessible with several EMRs, including TelisWolf, IntraHealth Profile, and MedAccess, and can be accessed by some of the physicians in BC and Nova Scotia. Next slide, please. Here is an example of the EFCGA in the EMR. The EFCGA interface largely adapted the paper version of the CGA form that was made available by Dr. Rockwood. Next slide, please. In helping with EMRs to achieve accuracy, robustness, and transparency of the EFCGA implementation, our research team also developed a standalone version of the eCGA and EFCGA software too, which can be used on any personal computer running the Windows operating system. The standalone software has been very helpful with EMR data standardization in this EFCGA research project. The standalone software is also being used by geriatricians and any other physician accessors who do not have an EMR EFCGA access for this research project. The development of the software is published in Frontiers in Public Health Digital Health paper. Next slide, please. Since the pandemic is a part of a virtual assessment and virtual appointment, during COVID-19 and in the post-COVID new norm, we updated the software by adding related items to better support virtual assessments of frailty. Information on COVID-19 vaccine is also included. The updated version has been received pretty well, judging by the increasing number of requests from different research groups in several countries for a copy of the software package to use with their projects. Next slide, please. To further increase the convenient access, scale up of the primary care CGA and data sharing potentials, we built an electronic EFCGA web application to address the gap in the field. We first conduct a survey to understand the status and needs as reported in this BMC paper. Next slide, please. The software tool has now been fully developed and thoroughly tested with additional care support from the Canadian Frailty networks. Here, I'm showing a screenshot of the EFCGA web app homepage, accessible online. It works with all common web browsers, such as Chrome in this case, and also the Firefox, Safari, Edge, and others. By clicking the buttons on the left side, users can log in and perform. The users will be promoted to the dashboard to perform several tasks of their choice. Next slide, please. For example, users can conduct a new assessment of the EFCGA and work with an interface showing the eCGA form. They can also perform analysis to get the basic statistics and the graphs of a data set. They may also check user menus and go through the training materials to better understand the EFCGA and its usage. Next slide, please. Users can also search, review, and edit the existing assessments. Selections of the existing assessments can be made in multiple ways. For example, search by patient ID, search by assessment date or assessment date range, search by age or age range, gender, by the score of a clinical frailty scale, or by the EFSCJ scores themselves. Next slide, please. The EFSCJ data collection is now in progress, despite the challenges, including COVID-19 related ones. To ensure completion of the project goal, we have been regularly checking, program solving many things. So far, over 20 clinics have participated in the project, with over 70% patient participants enrolled and over 30% assessment conducted. Note the exact number change depending on the time of review as the activities are ongoing. To benefit the future, for future data usage of project conclusion, we have paid a close attention to data quality control and improvement to reduce or record various kinds of possible confounders. Next slide, please.
Joey,
Using the initial, yes, I
let
just
you
got
know.
2 more slides. Yeah, using
Okay.
the initial assessment, we have done some data processing and analysis. For example, here I show to test the characteristics of the EFSCJ. We constructed the measurement with multiple iterations, with each using different sets of deficit variables. We examined the EFSCJ distributions and the empirical limit. We linked the EFSCJ scores with the clinical frailty scale. Further, we compared the EFSCJ differences between different cognitive groups. This result have been disseminated, will be disseminated through a poster presentation at the AAIC 2020 conference in July. Similarly, we analyzed the initial assessment data to understand how the EFSCJ scores by family physicians and the geriatricians compare. Data showed that a similar mean EFSCJ by both groups, the CFS and the EFSCJ were closely correlated by the both physician groups. The average the interclass coefficient was high. This is encouraging primary finding, and we plan to disseminate this result at the GSA, the Gerontology Society Conference 2020. Clearly, currently, these findings remain to be preliminary. All the tests must be redone when we have completed the dataset collection. The potential impact of several confounding factors, which we have been monitoring, must also be taken into consideration with data interpretation. Next slide, please. In summary, with considerable effort and hard work in addressing multiple challenges, the research project is on track with good progress and many deliverables. I will conclude my talk with this slide showing our ongoing effort in further developing the prospective arm of the EFSCJ research to achieve the project's objectives. With this, I would sincerely acknowledge everyone who has worked with us on the project development. And I thank everyone who helped and supported the EFSCJ research. And thank you very much for your attention.
Thank you so much, Joey, for taking us through this wonderful project. It shows immense value for, helping identify frailty, and also so it could then be assessed and deficits prevented in a system that will probably be quite implementable within a healthcare system through the family practice clinics. I'd like to now open the floor for if there's any questions for Joey. I have a question from Deveshi. What types of services or care do individuals receive who score a high frailty index CGA score?
Yeah, that's a very good question. At the moment, for this research project, we actually have a inclusion criteria to selectively enroll patients. So our criteria, in addition to age, there is a requirement for the frailty, clinical frailty scale value. So we focusing on the group who have the clinical frailty, which is a nine level frailty screening scale. So we focusing on those who scaled 3 to 6. So truly for these research projects, we don't enroll anyone really frail with anything above 6. However, they are like people that more frail or less frail, even in this research participation group. So the CARES and the BREAK, the clinical initiations that we collaborate, the physicians will make care planning based on their frailty levels and also their interventions, individualized interventions through social prescribing and also the community coaching program.
Thanks, Xiaowei. There are a couple more questions for you in the chat if you wanted to maybe address those, if you have some time. And then I think I'm going to move on to our next talk. I also would just like to note that our next talk, as well as the first two, all involved patients as partners in research to some extent. So I just wanted to highlight that for everyone, because it is a really important initiative and a new way of doing research that we are supporting in the Fraser region and across BC through the BC Support Unit. And so my next presenter is Dr. Janice Sorensen, and she is with the Long-Term Care Research Group in Fraser Health. And she's going to be talking to us about expanding research and embracing innovation in long-term care and assisted living in Fraser Health. Over to you, Janice.
Thank you. And you're able to see my slides?
Yes.
Excellent. And thank you very much for the opportunity to speak today and for the organizers for this event. And very excited to share of our research program within long-term care and assisted living at Fraser Health. And our introductions for this session this morning from Suzanne Fox. She's our executive director in integrated long-term care and assisted living services. And she alluded to a strategy, which I just wanted to start off with. And it makes me really excited as a researcher, because within our strategy and mission to deliver exceptional quality and excellence in care amidst comforts of home for our residents in long-term care and assisted living, one of the four key pillars to accomplish that mission is excellence through quality, research, education, and innovation, of which our research program has been quite instrumental and supported within the sector to support within our family and residents within their experience, staff and physicians, and as well within connecting people and communities, and within that partnerships and collaborations. So within our research endeavors and some of the key elements that have been instrumental within growing our program, and just to segue from what Meg was saying in terms of all of the projects presented this morning being with patient partners, first and foremost want to acknowledge that that's something we highly value within our program within patient-oriented research, and as such have formed a long-term care and assisted living research partners group, where we have ongoing engagement with diverse partners, family care partners, residents, staff, volunteers, to inform our research program, our priorities, and involved as patient partners in various projects that we have going on. In relation to that, we were fortunate to get some competing and collaborating funds from Michael Smith Health Research BC, where we're working at co-creating research priorities. Alongside our focus within patient-oriented research, we also see quite instrumental within our program, our support within leadership and also clinician involvement in our research. So I mentioned our executive director, Suzanne Fox, who introduced us at sessions this morning, being a key leader within our research program, but also in a collaboration with our regional medical director, Dr. Akbar Mathani, within physician services and long-term care and assisted living, strongly supporting and championing for research and innovation within the sector. We're quite fortunate that we do have some staff with clinicians with protected time. So one being a physician lead for research that has a day a week to support within our research projects. My role as well, and these roles starting within in 2020 when the research endeavors were established, and alongside that, and quite importantly, within funding, we've been able to get establishing a research unit and a team of supports with research coordinator, research assistants, research data analysts, to be able to have supports within doing our research projects. In addition to here in the Health Authority having our patient partners and also clinician involvement, we're very grateful for collaborations with academics. And we have within our group one of the first academic sabbaticals where a senior health services researcher has been embedded within our group and has had time to focus within supporting within and collaborating within research endeavors. And that's Dr. Valerie Crooks, who's a professor at Simon Fraser University, who's been working quite closely with our several projects. So within the projects we've been involved with, and as I mentioned, myself and within the focus within research in the sector, starting within 2020, happened to coincide with the pandemic. And so thus far, much of our research projects have had a focus within the pandemic, but quite a range of diverse topics. I was mentioning how our prioritization within patient-oriented research. So we've had some grants to establish our research partners group and also within priority setting. One of our early on projects looking at implementation of promising practices during the pandemic, our CAPLOG study, within increasing uptake of vaccinations amongst staff, looking at one of our bigger projects, looking at long COVID in long-term care residents, looking at experience of grandchildren within visitation restrictions, and then also looking at a new grant we just got to look at a utilization focused evaluation of virtual physician care rolled out during the pandemic in our health area here in Fraser Health. So quite a range of different projects, and I'm just going to share by the time we have today the first 4 projects, just to give an idea of some of the work that we're working on. So as mentioned, highly prioritized within our group patient-oriented research, and we're very grateful for some funding from the BC Support Unit for this project on fostering meaningful engagement in COVID-19 research and evaluation of long-term care and assisted living at the Fraser Health Authority. And within this, the supports we were able to have supports within recruitment and forming of this group, and an honorarium for our patient partners, so compensation for their time and their involvement within research. And over the summer into the fall of 2021, we took considerable time within finding and recruiting patient partners from the long-term care sector. And I think there was a question in terms of how do you find your partners as such. The first that we had to join actually within this project itself, her name Annette Burnt, I found within a learning opportunity through BC Support Unit on trauma resiliency informed practice. And then having some great advice we had within BC Support Unit. Beverly Pomeroy was a really great mentor within this project. So, Reach BC we used, as well as different platforms within social media. There's a number of groups that have formed within advocacy and within long-term care and assisted living, and particularly with what's transpired over the pandemic. So through these various different avenues, we've managed to recruit 5 family care partners, 2 residents, one from assisted living, one from long-term care, volunteer, and an LPM that are 9 partners within our long-term care and assisted living research partners group. It was in December that we had our first kickoff meeting. and had the tremendous graphic facilitation support within those initial couple meetings of Katrina Thorson. So you can see some of the notes and visuals and such, but getting to reflect on why are we here, learning together about what is patient-oriented research, what it is to be a patient partner within, specifically within long-term care and assisted living related research. What are our core values, and reflecting upon that within a group, looking at timelines, reflections, and what's next. What do we want to accomplish within this group? Because it became quite apparent that within our partners, that desire for their voice to be heard, and also to see some opportunity for impact, opportunity for action, and within their interests in being involved as patient partners. So it was a really great start within our group there in December. We had our first kickoff meeting, and then we've been meeting monthly in the group and discussing within the ongoing research projects we have, and particularly within this co-creating of research priority setting. And I think one of the key take-home messages and within forming this partners group is the importance within building of those relationships and having a safe space to be able to share one's and feel free to express one's experiences and ideas, and to feel that one is being heard within the partners group. And that's where myself as a researcher that is embedded within the health authority, we're having great accountability towards what is seen as meaningful and timely research from those most impacted by the research. So our residents, their family and loved ones, and the staff within long-term care and assisted living. So this has been a really tremendous opportunity for us to form this partners group and to work with the partners on this, where they're also, in addition to our meetings and connecting as a group, they're involved within specific projects as patient partners and compensated for their time within each project and also within the partners group. And I just wanted to share, this was from a research cafe session where we were reflecting on patient partners, Annette Burt, her experience within this, our PAPLOC study, which I'll be presenting shortly here. And I just wanted to pass along some key reflections and thoughts from discussions with Annette and within considerations when recruiting patient partners, this specifically from a family care partner's perspective, but considerations within where one is within their continuum of living or lived experience with long-term care assisted living, and how within experiences one has had that there can be trauma involved as such, and also with a lot of time and within one's capacity and availability to get involved with research in that. So thoughts and reflections within the timing to get involved with research, and also for researchers to be aware and cognizant of those considerations of where a patient partner is in their journey, and within reflections of how one is coming from their own individual living or lived experience with long-term care and or assisted living, and moving that from one's individual experience and going maybe beyond challenges or complaints one's have to constructive suggestions, seeing systemic complexities in the big picture as such. And these were some reflections from Annette Burt, one of our family care partners on the partners group that is involved with some of our research. And with these reflections was from our PAPLOC study, so a good segue to share of our first research project within the group, within an implementation science team's funding opportunity around strengthening pandemic preparedness in long-term care. Sonia Singh alluded to implementation science and gave some great background within what that is, and for within this particular funding opportunity, recognizing how vulnerable to outbreaks and within what's transpired within the first wave within the pandemic, of particularly in Canada, high mortality rates within long-term care, and seeing a need for investigating and supporting around implementing promising practices for pandemic preparedness and response. And so within this program, there was broad perspectives of promising practices within preparation, prevention, and response within pandemic outbreaks, focus within staff, also with inclusion within family, and care being provided in the home, whether it be COVID-19 or non-COVID-19 care. So quite broad within the various focus and topics that were dealt with in this national funding program for different cohorts of implementation science teams. And for ourselves, and looking at what topic of focus, we connected with some of our homes within the health authority. There were 6 homes that got involved, and it became quite apparent that each home had different individualized needs and priorities when it came to promising practices. So, and we also knew that alongside that, there was focus and investment within our sector within quality improvement, training for our facility medical directors, also directors of care, and so and also seeing within coordination and within the implementation of promising practices, came to the idea and focus within looking at how can we best leverage within quality improvement implementation within these promising practices prioritized in each home. And so that's where we came up with this study of an implementation of team-based quality improvement collaborative approach to pandemic preparedness in long-term care homes, and quite inspired by where we were and prioritizing quality improvement within the sector, and looking at the literature where it was in particular some work being done in the UK and Holland, where they had quite good success within quality improvement collaboratives within implementing practices and evidence-based practices. So within the pandemic circumstances, we were also looking at a virtual format within quality improvement collaboratives and how that our approach could support within implementing pandemic preparedness and response, and then also opportunity for sharing learning across the 6 homes that became involved within the study. And within that approach, we had focus within quality improvement teams being multidisciplinary, within having individuals of leadership, physicians, healthcare professionals, care aides, and also quite importantly, really encouraging the homes to recruit resident and or family care partners as part of the quality improvement team. We had provided supports for the homes within external mentoring, so QI coaches that met weekly for virtual huddles to support within their quality improvement projects. And within this PAPLOC study, also developing long-term care quality improvement tools that were specific within the long-term care context that could be quite helpful within their quality improvement. And then within the collaborative 6 homes involved, we had newsletters to share within the projects that were being conducted and learning, and then also facilitated lesson sharing from the QI coaches, where they were aware within what projects were being done across the various homes and potential for synergies across some of the topics that were being dealt with within the quality improvement projects. And then to tie that all together, and within the context of the pandemic, we used virtual collaboration communication platform Slack, also virtually used within connecting within meetings, Zoom often, within the weekly huddles, to be able to have those quality improvement coaches to support within the different homes where there was, particularly at the time within the project, restrictions within individuals within coming in the homes and such. So it allowed for collaboration also of family care partners and various individuals within the quality improvement coaching. So this project, it was conducted in 2021. So starting off in the spring and rounding off in November of 2021. So within less than a course of a year, just to have those perspectives of, this is a sector pressed within different outbreaks occurring, but alongside that in British Columbia, where if you remember within the summer, we had our heat dome, heat waves, we had also forest fires within the interior and residents being transferred to some of our homes in Fraser Health. So a lot of pressures within the sector and within our study needing to be flexible and adaptable within the pressures that were being faced within these homes. And on top of all that they were dealing with within the care provision, attempting to conduct quality improvement projects to champion for best practices within pandemic preparedness and response. And just to illustrate of the tremendous job that the homes did in terms of accomplishing within their projects. Now, different homes started off maybe at different start times and had different pressures involved. So the number of projects varied from 1 to 4 projects, and at different levels of how far they got along within their improvement journey. You can see on the right-hand side the numbers within illustrating from how far along they got within their quality improvement, from more from of a testing and a stage, but vast majority coming to a level of some degree of improvement, and even some sustainable improvement with this at the number of 4.5. And within the projects that were conducted, the project was set up that it was really up to the homes to prioritize and decide of which projects they wanted to address. And when I say the homes, these were these interdisciplinary quality improvement teams, including family care partners, residents, and different individuals and staff, leadership. And within that, they found that, having those family and residents came about certain change ideas that they might not otherwise thought of. So some of the examples here was hand sanitizer, realizing that, residents with mobility issues, that having sanitizer on with their tray at mealtime was quite instrumental to ensure with hand hygiene and such. Within family communication, posters around visitation and policies and such. And also within timely. So the one project around allergy history, we just had beginning off within the project rollout of vaccines. So it's important within that rollout to have updated that within the chart of the patients. And you can see within some of the homes, there was the same topic perhaps being addressed. So within, vaccinations, within grief, but each home being very unique within the culture with where they're at. And so these topics were dealt with maybe quite differently, and the learning quite different, and what was achieved quite different. So it really, highlighted within the unique needs within the different homes, and how this quality improvement collaborative approach was robust enough to support within, diverse priorities within the homes and different pressures that they're facing. Just to sum up with some of the key lessons learned, really highlighting the importance of that multidisciplinary component within the teams. So as I was saying, be able to be adaptable and customizable, and to, within the priorities and within the projects and different pressures being faced during the pandemic, the multidisciplinary component and different perspectives being quite instrumental within the change ideas and within being able to successfully complete the projects. Really, quite within the homes that had resident family partners, really seeing the great value and how different change ideas within success within implementing the promising practices being really quite instrumental to have that representation, and also for the resident and the family reflecting on how they found value being involved, to see a bit of us behind the scenes of what pressures that the care homes were being faced within the pandemic, and to support within that level, they found quite rewarding. Found that, the size of the quality improvement teams varied from 2 to 10 members, but ideally that size around 5 to 8 was found to be, a good size. That within the coaching supports, we were able to, have weekly huddles online, but it was seen that having some in-person meeting was valuable, and that having that continuous support being really instrumental to support within the teams. And then over time, the support maybe lessening as teams got more familiar within the quality improvement process, and mentioning of tools being developed. So this QI Pathway to Excellence tool is something that is still being used and within our quality improvement in long-term care and assisted living, and has been quite instrumental to allow for the different members of that multidisciplinary team to keep up to speed and to be involved with quality improvement. Within shared learning, that we found that there was opportunity for some collaboration, particularly to homes that maybe had some pre-existing relationships, and that within the virtual component, in particularly for the quality improvement coaches, that it was really helpful for them to organize and to support within Zoom and being able to do the huddles and such. In terms of the homes using the virtual collaboration platform, it was challenged by nature of care aides and LPNs. They didn't have access within computers, so that was a key learning from the project as well. Within the little bit of time left, I'm just going to give some snippets of a couple other studies. So one here was looking at the informed study within looking at increase in uptake amongst staff and vaccinations. So we had 45 interviews with individuals in roles of leadership within long-term care, reflections on improving uptake of vaccines, and came up with 6 kind of main questions and themes within improving vaccine uptake. And these are be plastic placard cards and posters that we can put up in the home to help inspire within improving vaccine uptake. So the importance of modeling within mentorship, opportunities for knowledge exchange, focusing more on encouragement and incentives as opposed to pressures and penalizing one for within vaccination, learning from others' experiences from outbreaks. So homes that have had outbreaks, or learning from homes that have outbreaks being a point to encourage vaccination, having experts available to discuss within vaccination decision making, and having personalized conversations and targeted information for those that are vaccine hesitant. So this was a really valuable project, and one where, in terms of knowledge mobilization, that we're at that point here to be sharing this across our homes in the region and beyond. And then happy to share of a publication that just came out. This is within our study looking at long COVID and long-term care home residents, and where we've published a call to action to enhance our understanding of long COVID and long-term care home residents, because within some review studies, we're really seeing a lack of research looking at this topic specifically within long-term care. Within this project, we are currently doing a retrospective cohort study, a qualitative study, and a rapid realist review of this topic of long COVID within long-term care home residents. So more to come within that topic. And last but not least, a big thank you to our sponsors within the various projects that I presented. And very importantly, and in yellow here, to our Fraser Health Long-Term Care and Assisted Living research team, staff participating in long-term care and assisted living homes, residents, family, and staff that have involved in our research. Thank you so very much. The sector has been so pressed during the pandemic, and I'm completely blown away by the engagement and interest within our sector to be involved in research and championing for research and innovation at this time. So thank you for your time to listen.
Thanks, Janice. Very impressive overview of what you've been able to accomplish in long-term care research in just about a year and a half, wasn't it? That you guys got the program up and running.
Pretty much.
Yeah, and you guys have really been movers and shakers, and really need to be applauded for the successes you're having and all the research grant funding that you're bringing into the organization. I'd like to open the floor now for questions for Janice. I've got one in the chat. Janice, what project are you most excited about at the moment? It's a fun question.
Oh, that's a hard one. And this is from my colleague, Ian Fife, who's a research assistant in our group. To be honest, and it's something that intersects across all our projects, but within that patient-oriented research focus and our long-term care and assisted living research partners group, I am so excited by the engagement and level of dedication and trust that we're building within that team. Because I think that within, as being a researcher within the health authority, I think that's that opportunity to be able to have their voices to be heard, and to have that thought within our research priorities and how we're conducting our research. So that's what really excites me at the moment now. And it transcends across all our projects. So in some ways it covers it all.
Thanks, Janice. And one more question from Bob Strain. As a patient partner and having taken in the 3 sessions this morning, especially, thank you for everyone who arranged them. So it's more of a thank you than a question.
Thanks.
I'm just doing a quick scan to see if anyone has their hand up. I don't see any further questions. So just give it one more minute or 30 seconds for people to madly type something in.
And I think also maybe just as we're waiting for people to put out a pitch there, if you are interested in research in long-term care and assisted living, and particularly those that are of a, maybe interested in being as a patient partner, do not hesitate to reach out. Happy to hear from you.
Okay, so I think I'm not seeing any more questions at this time. So I'd like to thank you, Janice, and all our speakers today. And in closing, I also like to thank everyone who joined us today for this morning's session. The next session is on Indigenous health, hosted by Island Health. And it actually might already be ongoing, started, I think, at 10, but you're welcome to switch over and join if you have the time or inclination. And Camille should be putting the link in the chat for that one. And then I just want to wrap up by saying that I hope you found this event interesting and able to take something useful or inspiring away with you to apply either in your workplace or your personal life. And I wish you a wonderful day. Thanks for joining us.